Okay, I think we're going to go for it. So one last call, please rename yourself, first name, last name, and then academic discipline, just so we can see who we have if you haven't already done so. But everybody else, thank you so much for being here. We appreciate it. The first AHEC Scholar Seminar of the spring semester. We're really happy to have you all here. I did want to make one quick introduction for a new face to the AHEC Scholars team that's on here, which is Emma. If you can see her there, she's waving her hand. She just joined our AHEC Scholars team about a month ago now. And then you'll also see, she's probably hopping on shortly, Jillian Hull, who's also a new addition to our AHEC Scholars team. So we're excited to have them both on board. So, and then in terms of the presentation for today, we're really excited to have our health equity specialists from our AHEC regions across the state of Montana joining us today. So we have Chelsea, who is a part of our Western AHEC. We have Jessica, who's a part of our Northeastern AHEC. We have Chloe, who's a part of our North Central AHEC, Maggie with our South Central AHEC, and then Amy, who's representing our Eastern AHEC today. So I'm going to turn it over to them. They're going to kind of take the reins from here.
Awesome. Well, I was happy to get started. I didn't know if we wanted to do any little introduction to just kind of get rolling with it, because that's totally fine. If so, if we were planning, but that's also fine. We can just go and get into it. What do you think, Chelsea?
Yeah, Chloe, I'm just having a hard time. Your audio's just a little distorted. Yeah. It's setting up those new offices. They'll get you every time.
Is that better? Okay. We're still not quite there with the speaker, but we will get there. Hi, everyone. I'm Chloe Williams. I'm the North Central Montana AHEC Equity and Community Engagement Specialist, and I will be kicking us off today with our PowerPoint. So let me just go ahead and share my screen. All right. And everybody let me know if you can see okay. Perfect. Let me just get up. All righty. All right, so thanks for being with us today for the presentation. We are, as Mandy mentioned, Chelsea, Maggie, Amy, Jesse, and Chloe. Oh my gosh, let's see. Uh-oh. Okay, where's... Sorry about that, everyone. I'm seeming to have some technical difficulties. My sincerest apology. All right. So we're going to move on to a land acknowledgement. We acknowledge this meeting is taking place on the land of tribal nations whose time in the area range from tens of thousands of years to hundreds of years. Montana is home to 7 sovereign nations on reservations and 1 non-reservation sovereign nation. Those of us who are not Indigenous acknowledge we are settlers on this land and benefit from colonization and the impression of Indigenous people in the past and present. We also benefit from the purposeful erasure of their history and ties to this land. We recognize their connection to the state and give thanks for the opportunity to work here. And so we're going to just start by going through the basics of why and how we began this work. So we are grant funded by the CDC COVID-19 Health Equity Grant, which came about pretty much following COVID-19. Not that health equity did not exist prior to COVID, but it really did, unfortunately, highlight the magnanimity of disparities across the nation. And so the CDC has and will continue to put a lot of money into addressing health equities that were highlighted by COVID and other disparities and, pandemics, epidemics, hopefully not to come forth in the future, but inevitably. Our grant for this cycle began in February of 2022. Most of us were hired later in this spring and early summer. So we were a little bit late to the project, but really excited and have gone really, really far with the time that we have had. Each region, so each of the 5 AHEC regions has a specialist working on our equity project. And so we couldn't do any of this work without our amazing partners and those who went forth with acquiring funding from the get-go. And that would include Montana DPHHS, the Office of Rural Health, which includes the AHEC and MSU. And so how our Health Equity Task Force has worked from February of 2022 to this point is we began the project with our task forces by going forward with a regional SWOT analysis. And a SWOT analysis, if you're not familiar, is strengths, weaknesses. Oh my gosh, and now I can't. Let's see. Strengths, weaknesses, and
Opportunities.
And threats.
Oh, Chelsea. What was that?
Strengths, weaknesses, opportunities, and threats.
Gotcha. So my speakers aren't working either. That's and threats. So we will go deeper into that because each of us will be talking about our SWOT analysis through our regional task force. Quarter 2, which was May of 2022, identified priority areas. And so we met with our task forces every month regionally to go forward with, discussions, lived experience, and just talking about what priority areas, and so areas of most need, we could identify within our communities. Quarter 3, which was August of 2022, consisted of data and resources to identify interventions. So we asked our task force members and, we ourselves did a bit of data dig on our communities, resources so that we don't duplicate efforts, and ways to identify interventions that we could bring forth in a way that we could apply for funding or would have backup and validation for needing resources. Quarter 4 consisted of interventions, inputs, outputs, outcome, and impact. And so we're really, really focusing on a lot of work in terms of what interventions are, feasible, how we go about that. Do we continue work that's already being done, but expand upon it? And each task force is a little bit different about how they approach that. February of 2023 is final recommendations. We have deviated a bit because we did receive a no-cost extension. And so we've been able to continue our work for a bit longer than I think was anticipated, especially within our task forces. And so I think we're still kind of mulling over interventions, ways to go about the work that we are going to do and how to most intentionally and meaningfully go forward with interventions, implementations, and doing things that will best support our communities. And so I wanted to touch on critical access hospitals. I don't think this is a super unfamiliar topic for those who are on this call, but we wanted to make sure, because we will be talking about them quite a bit in our presentations, because some of our work does center around critical access hospitals throughout the state, that there's a little bit of a foundation placed for that. So you may see them in literature referred to as CAUSE. They are designation that is given to eligible rural hospitals by CMS. And the whole idea is to invigorate a hospital economically so that they can stay in more financially vulnerable areas. And that is often rural, remote, frontier areas that are needing services within their community. And they do have specific requirements that make them a little bit more unique. As you can see, 25 or fewer acute care inpatient beds, they have to be located more than 35 miles from another hospital. So that kind of speaks on the remoteness of these facilities. And they have to have 24/7 emergency care services. Montana itself is home to 49 critical access hospitals. So very, very relevant to the healthcare facilities that we have throughout the state. And we are really fortunate to be able to work with the Office of Rural Health hand in hand in creating more equitable approaches for these hospitals. All right, so we're going to roll on into the North Central Equity Task Force, and that would be my task force. If you take a look at the map, we are the North Central region is the lighter yellow of the map. And so we span from west to east, from Glacier County to Blaine County, and from the High Line down to Matter County. And so I did a little bit of a description in terms of our geography. We are, the North Central region is home to 11 counties. We are exceptionally fortunate to also be able to support and work with multiple different tribal nations as are listed above. And that's been really, really exciting. All of our communities are considered rural and frontier, and most, if not all, are federally designated HPSAs, or health professional shortage areas. And HPSAs are, designated based on overall service area, the defined service area, and if it's able to just demonstrate a critical shortage of PCPs, dentists, or mental health professionals. And overall, they do not meet the needs of they don't meet the healthcare needs of that population. And so I think that's really relevant in terms of the healthcare professional shortages throughout the North Central region. And I would say that it probably stands for most of Montana. Most frequently reported barriers to care are consistent with distance to services, broadband availability, as I mentioned earlier, healthcare professional shortages, and experiencing discrimination in the healthcare setting. And just a little synopsis of the North Central Task Force. We have around 34 members, and every meeting's a little bit different. Everyone's a little busier, dependent upon when they can and cannot come. But I will say every meeting is exceptionally insightful and robust, and we have a lot of feedback. And you can take a look, but we do have task force members from multiple different organizations. We have different community partners, and we are really fortunate to have community members with lived experience who also participate and share during meetings. And so, as I mentioned earlier, and there's the opportunities. This is our SWOT analysis that was completed for the North Central region. And I just wanted to highlight a few of the sticky notes that were placed. Because North Central is a rather frontier rural area, small town collaboration is a huge strength that we like to highlight. People really care about their communities, and that is a huge, huge strength when we're trying to make equitable moves forward. There is an increase to access to telehealth services due to COVID, and that necessity to have services that were able to be done at home and not in a clinic. Weaknesses, and you'll probably hear this across the board, but lack of transportation and distance to service is a huge barrier to care that people in the North Central region are experiencing. Also mentioned are community members experiencing a substance use disorder, opioid use disorder, rapidly aging populations without the necessary resources to age in place safely. Opportunities, lots of opportunities. I'm a silver lining person, so definitely we have a lot of increases in community-based programs, chronic disease management. There's a healthcare workforce resilience. People like to stick around their communities, and that's really, really exciting. And there's increased educational academic opportunities through tribal colleges in the region. Threats, trust. There's a lot of mistrust, especially regarding our tribal nations, healthcare organizations, state organizations, groups that make promises that are not necessarily delivered upon. Workforce recruitment and retention can be difficult. Retention, not as much, but definitely recruitment. It's hard for our critical access hospitals, especially in more remote areas, to convince people that they are the more exciting place to work at. And then once again, distance and lack of transportation services to medical centers. All right, and so moving on, we did, as mentioned earlier, we did go ahead and choose 3 priority areas, not to say that there are not many priority areas that need to be acknowledged for the area, but when we narrowed it down to 3, these are what kind of floated to the top in terms of most important at the time. And so supporting AI leadership and health equity, and this includes cultivating meaningful and intentional relationships with our tribal nations, supporting health equity areas most important to each individual tribe, and connecting tribal nations with resources when asked and appropriate to support tribal-led efforts in health equity. Increasing access to care through transportation services within the community, which will include expanding upon services that are already available, or perhaps need funding or other resources just to get them really going. And then aging services. We want to support organizations and programs that enhance abilities for aging community members to safely age in place. And we also really want to add support to respite care for those family members who are now taking care of their loved ones due to the lack of long-term care facilities in the region. So I know I mentioned earlier, I know I keep saying that, we just keep looping back. North Central Critical Access Hospitals. These are all the critical access hospitals in the North Central region. There's quite a few, and they all have been or will be doing their CHNAs in the next year or 2, and that is a community health needs assessment, which we assist in, and I will go more into depth in this slide. So community health needs assessments, they're done every 3 years. Office of Rural Health generally is the group that puts these on, but I know that some tribal nations and some specific hospitals do them with their public health departments as well. So there are a couple ways to get your community health needs assessment completed, but it is something that is mandatory for tax purposes or nonprofit status. It's one of the 2. It gets a little convoluted, so I won't go in depth with that one. But when I got started, Logan Health Pet Bank and Conrad and Mountain View Medical Center were already in the midst or towards the end of their CHNA process. However, I was able to meet with the CEOs, meet with the steering committees to go a little bit more in depth into ways that they can approach more equitable solutions. So that's pretty much our role. We bring an equity lens to basically changes that the hospital can make to meet community needs. And we will have upcoming CHNAs that are upcoming and ongoing. Logan Health Shelby is going through theirs, as well as Benefits Teton Medical Center. But overall, I would say in the North Central region, everyone has pretty similar needs or ways they're going to approach community needs in the way that they want to increase access to care, which will include educating the community on services that they have, decrease chronic disease prevalence, and one really large, and once again, I think will be resonate across the state of Montana, is increase and enhance access to mental and behavioral health services. And so it's not an exhaustive list, but those are a lot of the needs that we're finding through community members who are surveyed in the community health needs assessment regarding what they've experienced and how they feel the hospital could make that better. And so one thing I wanted to touch on, and this is kind of outside of the work that I do within the task force, is this is another health equity kind of work that I do. It's on a separate grant. However, it does have a lot of overlap with the work that's being done throughout the state, or mostly within the Southwest Montana region, which is so funny, right? Like I'm the North Central task force, or excuse me, I'm the North Central equity specialist and doing stuff in Southwest Montana, but it's all, it keeps things exciting. But before I get rolling, I work with the the St. James Intermountain Healthcare RCorp, which is the Rural Community Opioid Response Program. It's a nationwide program that is awarded to different communities, different states throughout the country. And our program in Southwest Montana is specific to pregnant and parenting people experiencing substance use disorder and opioid use disorder. And a lot of the work that we do is anti-stigma education, outreach, match treatment, implementation, and expansion of services. The 5 counties that we service are the Butte Silver Bow counties, Madison, Deer Lodge, Beaverhead, and Jefferson. And it's been a really wonderful opportunity to bring equity forward in a field that is carrying a lot of stigma, especially within communities, and helping to educate on compassionate care. So that is the wrap for North Central. Thank you so much for listening to me kind of ramble on. I really appreciate being here with everyone, and I will stop screen sharing.
All right, well, Chloe, that was awesome. It is my turn. I am Jessica Clam, and I'm here in Miles City at the Northeastern AHEC. I'm their equity person. So Chloe actually touched base on a lot of what I had. So I'll probably just kind of fly through mine. Thank you, Chloe. I'm screen sharing, right? Yep. What's that button do? Oh, okay. All right. So Northeastern Montana. I am way over that moving screen. I'm the orange. So the most rural slash frontier, you guys kind of know, but I didn't, because I'm new to this and I learned something new yesterday when I was prepping for this. So apparently, if you are in a rural community, that means you have about 10 people per square mile. And if you are a community so have the most critical access hospitals, which are 15. And we also do not have any primary physicians on staff. They're staffed with mid-level physicians. So unless they grew up, and we're really trying to work hard on making it appealing to people to come and help us out. Well,
Jessica?
apparently I put that one. What?
Can you turn off your camera? I think I'm getting some weird feedback, and I'm wondering if maybe rural Montana is giving you a run for its money today. Could you turn off your camera and see if we get a better connection?
Dude, how do I do that? Where am I at? Oh. So I hid my self view from myself so I don't stare at myself.
Thank you.
Did that work? Thank you. I was like, I can't find it, and I'm new to this Zoom presenting stuff. Okay, so onto this one. Is it better? Okay, so we have 32 members. I broke it down. 5 of them are critical access hospital members on our task force that meets monthly. 4 of them are community workers, 6 of them public health, 3 are in education, and 14 of those members are just different agencies around our community. So Chloe already went over what we did each quarter, so I'll just sneak to the next. So with our SWOT analysis, we identified strengths, which were behavioral health, coalitions, willingness to build positive and supportive relationships, the resources that are available, A couple of the opportunities were like high school career paths into education and also partnerships across the state. And threats, housing market and access to care. So we kind of narrowed it all down to the equity. So just trying to build trust and relationships. Also having things be American Indian led in efforts and leadership. And for provider information or education, sorry. The next one is kinds of things and workforce. So housing, burnout, recruitment, retention, everything that you can think of that comes with workforce, that's what we're trying to help. So for actions, in our tribal leadership and health equity, I'm excited. There's a group of us go with Stephanie Ironshooter, and she's going to show us around, and I'm really excited about that. And then behavioral mental health, we haven't really figured anything out programs wise or anything like that we can do with that right at this moment. Workforce, we're just working on bringing students into assessment. What is it? It's a survey. It evaluates the health needs and assets in the community, and it's typically done every 3 years. So out of the 15 hospitals that we have had 5 that has completed them. And I kind of listed them out, and then I listed their like health priority cares, I guess, for what they came. So, and I won't read them all to you, but if you kind of look under there, there's behavior health, access to care, patient access to care, behavior health. They all kind of mix in between, and which is good because it helps us know that our task force is on task. So additional work with the hospitals that we're doing, we're trying to bring more students to the region in hopes that they'll like it and they'll want to stay. We're also trying to assist in the CHNA process. And we are offering continuing education through Montana Health Network. And other equity work, we're just trying to establish care that is equitable and available. So as you can imagine, we're really far spread out. So, you know, people have to travel really far to get to their closest facility, most of them, like at least 60 miles or more. And so trying to figure out how to make that easy. Issues there, because who knows if their internet works. Apparently mine does not work very well. And yeah, that's about it. So again, I'm Jessica, and I'm going to hand it over to Amy.
Thanks, Jessica. Can everyone hear me? Okay, I'm going to go ahead and turn my video off as well, because I think in my corner of the building it tends to get a little spotty. And then let's see here. Hold on. Someone remind me how to switch this, because are you guys seeing the notes version?
Mm-hmm.
Yeah, which display settings is that? Yeah, swap. There we go. Okay. So I am Amy Queen. I'm the program manager for Eastern Montana AHEC. We are in between health equity specialists at the moment, so I'm going to cover this. I'm going to go fairly quickly just because I don't want to be repeating information that has already been covered. And then I am going to give a quick shout out at the end to our Riverstone Health Senior Director of DEI, who will be stepping in to help with some task force activities. And so our host organization is Riverstone Health. As far as the region goes, we are the blue region there, and we serve 12 counties that covers approximately 30,000 square miles. And we have several post-secondary and postgraduate schools in the region that we're working with. That includes MSU Billings, Rocky Mountain College, two tribal colleges, so Chief Dillknife College and Little Bighorn College, and then the medical school that's going in, Rocky Vista University. In terms of the critical access hospitals in our region, there are 8 in the region, and you can see them listed here. I won't go into detail with each of them. And then task force membership, we are working to grow the membership right now. We're at 22. That includes 8 representatives from healthcare, 3 in education, 6 community partners, and then 5 that are state or Montana Department of Health, Public Health and Human Services. Some areas that have been identified that we'd like to build out more are tribal contacts and disability contacts as well. And then our task force, of course, went through the same process with the SWOT analysis. The priority areas that were identified out of that included the 3 top areas that we went with were access to healthcare, American Indian leadership in health equity, and then sort of a combined behavioral health, substance use disorders, and mental health were the ones that we were focusing on. And so going forward in this coming year, some areas of opportunity that we're considering, and I imagine this will kind of morph and change as the year goes along, but that includes mental health screening education, addressing some of the telehealth infrastructure and equipment that can be an issue in rural spaces, working with facilities on potentially establishing some telehealth satellite centers. We've had some task force members that have tossed out some really excellent ideas in terms of, maybe using libraries or other public spaces for that. Providing some telehealth or digital literacy, and that includes for healthcare providers, and then health equity education surveys for the local facilities. And apart from the task force, some areas that Eastern Montana AHEC is looking or is currently working on through the health equity lenses, there is a sort of defunct health equity library at our local public library. And so working with both Rocky Mountain College and MSU Billings to get that up and running and probably provide some digital content as well that would be available that we could share really across the state because that interlibrary option. And then taking a look at training options as well so that we're really impacting the region that we're serving and able to provide, meet some of those needs that they have. And so taking a look at providing just a general health equity 101, also looking into the possibility of providing a health equity integration for EMRs. And then within that, we have discussed the possibility that if, say, there's honorarium options, looking at creating some type of fund that would really feed back into providing student services so that if students have a particular need while they're doing a rotation or a shadow session here at Riverstone, that we could help support them with those needs through any training honorariums. And another area that Eastern Montana AHEC has been taking a look at is our demographic form. For HRSA reporting purposes, we do collect demographics for both trainings that we facilitate, as well as any of the student rotations that occur here at Riverstone Health. And we have taken a look at that so we can really make it a little more robust, splitting legal sex from gender, adding veteran status and tribal affiliation, as well as ability status. Those wouldn't be required for HRSA reporting, but would really help inform the work that we're doing, and in turn, maybe provide some data going forward in terms of additional grant funding. And so, keeping it short and sweet, I'm actually moving into a new role with the program here at Riverstone that facilitates the community health needs assessments for Yellowstone County. And so Clark Sturgis, who is on the call today, I don't think he has access to a camera right now, but he very graciously is going to be providing some support to Eastern Montana AHEC's Health Equity Task Force while we're in between equity specialists. And so he's the Senior Director of DEI here at Riverstone. Very fortunate to have him. Excited for him to be on board. And I've included his email and phone number there if anyone wants to be in touch with him for more information. That's all I have. So thank you very much.
All right, thanks, Amy. All right, my name is Maggie Hodges. I'm the South Central Montana AHEC Equity and Community Engagement Specialist, and so I will get rolling on the South Central region. Our region encompasses 11 counties, starting in Lewis and Clark County, and then south to the state line in Beaverhead County, and then we go from Granite County across to Park County. And so we have 9 critical access hospitals in the South Central region. They're located in Phillipsburg, Anaconda, Townsend, Dillon, Sheridan, Ennis, Big Sky, Livingston, and Deer Lodge. Most of the medical and social resources in the South Central region are located in bigger cities like Helena and Bozeman. The rural areas depend heavily on farming and ranching, and tourism in some of the areas throughout the region. Our region has a high veteran population and a high 65 plus aging population compared to other areas in the state. So our task force members, we met on January 3rd and had 20 members attend, which is close to our average number of attendees. A snapshot of our last meeting. We had Linda Cletus from Montana No Kid Hungry present on Buddhist medicine work that is happening around the state. And then Stephanie Ironshooter from DPHHS facilitated restorative circles around the topic of lateral oppression. So our meetings generally comprise of open-ended discussions around our priority areas. And generally once a quarter, we'll feature a relevant guest speaker. Our membership and all of the task force memberships are made up of a group of people from a variety of different organizations. We currently have 11 members serving from a community group, 4 members from a public health department, 5 members from the State Department of Public Health and Human Services, since we are located in Helena, 7 members from healthcare organizations, 3 members from a college or university, and 2 community members. We've recently been joined by Montana Disability Self-Advocate, which has been really exciting and really opened up some great conversations with that lived experience, and we're really grateful for their participation. The South Central region and all of our task force have an open enrollment, open door kind of policy, and so we're always welcoming new members. If you are interested in joining one of the task forces after tonight's call, feel free to reach out to any of us, because we really are happy and really love having new people join us throughout. So for our SWOT analysis, the strengths that stood out to us were passionate people doing the work. We have a lot of community coalitions in the South Central region and a lot of public health resources. Some of the weaknesses that came to the surface were housing availability and affordability, a lack of service knowledge, and the information being hard to find to connect people to resources. Our potential areas of opportunities include better communication between efforts and groups, not adding burden to organizations that are already doing the work, and then looking at health equity for Indigenous populations. The threats that were identified were the highly politicized nature of equity work, how to get funding, and then not enough funding. The priority areas that the South Central region is focused on is behavioral mental health, aging services, and service coordination. So when it comes to the behavioral and mental health conversation, the majority of our conversation has centered around making communities more responsive for people who might be experiencing a mental health crisis. One way that this continues to surface is by finding a way to train either EMS providers or other first responders on responding to people who are experiencing mental health crisis. For service coordination, we have a lot of this discussion centering on how to contribute to service coordination in a meaningful way that is effective and not recreating the wheel, and that stays relevant after the task force work is done. And then finally, when we talk about aging services, we've been discussing and exploring ways to connect this priority area to service coordination and how to encourage home health care for aging populations in the South Central region. One of the projects that Chloe and I are working on together outside of the Health Equity Task Force is the Montana Index for Healthy Communities, or the IHC. This project was started to create an index that reflects the unique needs of Montanans using Montana's specific data from hospitals and other sources. This index uses social indicators such as internet connectivity and housing availability combined with clinical indicators to create zip code level rankings. And so this project started with a data collection phase, including informational interviews and an advisory committee made up of a variety of community organizations, hospital representatives, and people with lived experience, to really ensure that the variables that were selected for this index were meaningful to Montanans. We recently started a pilot phase with 2 Montana hospitals, Francis Mahone Deaconess in Glasgow and Beartooth Billings Clinic in Red Lodge. We're really excited these hospitals are using the index and their scores to create community-driven interventions to address health disparities in the neighborhoods that they serve that need it most. One of the most exciting things for us since entering the pilot phase has been seeing how the index scores reflect the experience of those living in each of the communities. Here's my contact information. If you have any questions or are interested in joining the task force, please do not hesitate to reach out. Chelsea.
Thank you. One second. Okay, can everybody see that okay? Great. So because of time, we're going to get through this and then we're going to quickly summarize what we're going to do in our little breakout rooms so that we can meet together as a group by no later than 6:20 to wrap up by 6:30. So my name is Chelsea Bellin. My preferred pronouns are she and her. I'm a member of the Yankton Sioux tribe and I'm originally from Washington State, but I've been in Missoula for about the last 13 years. So I am in the upper left-hand side. I would call it pink, but maybe it's like a coral color. It's within 7 counties. So that's where I'm at. I'm at U of M in Missoula. So the task force members for the Western region is comprised about 39 to 40-ish members, give or take. There's a lot of individuals that just like to take part, listen, but don't really like interact unless it's with ideas outside of the group, which I feel is, just as beneficial. There are 7 counties within the Western region, and you'll see them listed on the left-hand side. And then we have the pleasure of serving and supporting the Flathead Reservation. Representation within the task force members are within public health, hospital programs, tribal and urban Indian health. We have Missoula All Nations as our urban Indian health center. And a lot of community members have found that they feel comfortable voicing their opinions and their lived experiences within this regional set, the meeting set. So there's also nonprofits and medical providers that take part in the conversation, and then academia programs that support health sciences and advocacy are also present in the task force. And a lot of these individuals kind of can fit into multiple categories and not just one. So it's a really great integration of community and education. Again, everybody did a SWOT analysis. I'm not going to go through it a whole lot, except for the fact that a lot of what we saw across the state that we pointed out in Western was, accessibility, but also the accessibility in terms of behavioral health. Behavioral health was a huge barrier. It was a huge weakness. It was a threat. And ultimately, it could be an opportunity for our whole state to strengthen. So the 3 priority areas for the Western region: American Indian leadership and health equity. Again, I believe Jessica mentioned it. It's really about the ownership and the leading of healthcare and community-driven projects led by tribal nations. The second one is LGBTQ plus education and healthcare. And I'll go into that a little bit more. And then behavioral health and substance use disorder. And again, these three are like every priority area, it feels like, is a huge umbrella with many different issues underneath that umbrella. But these were the three areas that our members felt the most passionate about in terms of digging a little bit deeper into the topic and becoming educated. So deeper discussions, briefly to go through this, American Indian Leadership and Health Equity really focuses on food sovereignty and access to food, and not just, garden beds and supporting food banks, but including younger generations with the elderly and creating relationships, especially after COVID-19 and the mental health issues that came with separating families for such a long time. Nursing workforce retention has also come up in terms of how to keep graduated nurses within their communities. LGBTQIA+ education and healthcare really comes down to safety in rural communities and how the simplest acts can create a safe environment for this community. Simple word changes within intake forms, introducing themselves, like a provider can introduce themselves with their pronouns to let them know that, they encourage that and that they welcome that. And then also just training overall for inclusive language within a healthcare setting. We've had Glacier Queer Alliance take part in our task force, and then also with AHEC as a whole. And they did a wonderful job about giving a presentation about breaking down acronyms and basically, what they are, what they mean, and how understanding acronyms can really enhance a relationship with the LGBTQ community. Behavioral health and substance disorder. What we found in Western Montana is the lack of accessible detox centers and very few MAT providers. And then there's also just now a kind of a uptick in interest around harm reduction efforts. And so we're continuing that conversation, not just with syringe programs, but also pathways of discussions and support for youth in suicide. Again, everybody's gone over the CHNA and CHIP process, so I won't speak too much on that, except for the fact that what's happening in my region right now that I have not seen yet in the last year is hospitals, public health offices, and other community health establishments are teaming up together and creating a community or county-wide needs assessment. And that's just not something I came across when I first started. And so seeing that process from the very beginning has been really beneficial. And that's with the Cabinet Peaks in Lincoln. Community health workers is something we're also supporting. And that's simply, providing additional education, finding out if they need resources from our end when it comes to health equity. And then something that I pride and really focus on is the relationship building of community and healthcare systems and cultural communities, collaborative projects with various healthcare centers. We really don't want to recreate the wheel. And then most importantly for, members that are underserved and populations that, maybe need a little bit of support is the health literacy for community members when they're seeking out their care. So, just a brief moving forward goals when it comes to the region, the Western regions task forces. I'm really trying to engage a little bit more with LGBTQ organizations. There's been some really great conversations, and I think the community and the way that they have been treated by healthcare systems historically is there just needs to be some trust built there. And so to make sure that there's a safe place where people are being heard is kind of, my main priority. And I'm really adamant about supporting community-based organizations. And so supporting healthcare, grassroots, nonprofits with grant writing that relate in increasing healthcare services. That is it. I'm going to send it over to Chloe so we can wrap this portion up and we can move forward. But questions, comments, please let me know.
Thanks, Chelsea. Can you guys hear me okay? All right. I'm gonna share my screen really quickly. Ignore. Everybody see that all right? Sorry, I'm like super stressed because like technology has not been my friend today. So So we're gonna do a quick health equity overview just to lay that foundation regarding health equity and how best it can be applied in the work that you all do with AHEC. And so one thing I wanted to touch on was equality versus equity. The definition for equality is that each individual group of people or community is given the same resources or opportunities. Meanwhile, equity acknowledges that each person has different circumstances and distributes the exact resources and opportunities that person would need to reach an equal. This is a newer image created by the Robert Wood Johnson Foundation to try and create a visual for equity and how equity and equality are two very different things. They're both very positive, but equity recognizes that everyone starts in a different place. And so we have to meet people where they're at and give them the resources that allow them to succeed in a way that is creates essentially. And so what is health equity? I believe it's WHO, well, the World Health Organization, defines health equity as being achieved when every person can attain their full potential for health and well-being, and is determined by the conditions in which people are born, grow, live, work, play, age, and furthermore, a wider set of forces and systems shaping the conditions of daily life. And so those external variables mentioned are, and I'm sure you're very familiar with this, are the social determinants of health, also known by the acronym SDLH. And those are the conditions that dictate health equity and the ability for every person to attain their utmost health potential. These are non-medical factors. These are factors that are found in your built environment, that are found in terms of educational attainment, in terms of economic stability. And as you can see listed below, those are the most commonly referenced social determinants. And so breaking down the more commonly referenced SDLH factors or variables that we see in health equity. In terms of education, access, and quality, that's a correlation between education, health, and overall well-being. And so this includes educational attainment, language literacy, and early childhood development. Healthcare and quality alludes to access to health services and the understanding people have available health services and their overall health, which is also known as health literacy. So this includes primary care availability as well as health insurance. Neighborhood and built environments are the association between where a person lives, so housing, their neighborhood and environment, and overall health outcomes, which include housing, quality of housing, transportation, food access, so that if someone is food insecure or food secure, environmental quality, and local context. Social and community context is a relationship between the attributable contexts in which people live, learn, work, and play. And this includes discrimination and conditions in the workplace, as well as incarceration, as examples of where that falls in these variables. Lastly, we'll touch on economic stability, which is the relationship between financial resources and overall health, which include poverty, employment, once again, food security, and housing stability. So some of them definitely have overlaps. And one thing I really want to touch on, because I think even including the social determinants of health external variables, structural determinants of health are the baseline. They are what determine the distribution of these social determinants of health to any single person. And then those include cultural norms, policies, institutions, principles, and practices. And what I really want to touch on is that structures and systems in the United States date back to early colonization. And they're often, if not always, based on racial, class, and gender. Health inequities occurring in present day are results of years of oppression, racism, cultural genocide, and discrimination. And so taking all of that in when you are thinking about inequities and what people are experiencing is exceptionally important as a healthcare provider or someone who is working in the workforce in terms of, patient treatment and, if a patient is able to follow a treatment plan. I think it's really great to always let every person have a different situation and inequities that work has upon them and not vice versa. So it really is important to note that structural determinants shape the distribution of both power and resources across the population, often, if not always, resulting in that. Chelsea, I'm going to pass it on to you.
Okay, so I'm going to go over what our breakout sessions are going to look like. And we're going to have about 20 minutes in those breakouts, and then we'll come back together and finish up the discussion with a larger question. But in case anybody doesn't know what a circle discussion is, or they're also known as like healing restorative circle talks, it's an Indigenous-centered teaching and approach to having conversations that you then practice listening rather than responding. And so the point of this is to, everyone is going to be in a safe space. What is said there stays there. Everyone's going to get a chance to speak and listen. Nobody is required to speak, but I encourage you to take part in the conversation and be really reflective. So there's no correct answers. Nobody's going to get extra points, for sharing. It is really just about sharing your perspective, maybe your own lived experiences, and your own perspective of living in Montana. And again, the whole idea around circle discussions to have this equal sense about each member that is in a circle. And in the Indigenous culture, we view a lot of things in a symbolic way of a circle. So circle of seasons, circle of life, everything's ongoing and equal. So as we enter into this space, we're going to have 4 different breakout groups, and one of our health equity specialists is going to facilitate it. And again, it's really not going to be a requirement to speak, but we are going to call on each person and hopefully have a space where you can reflect. We are not going to respond to it. And then when we come back, based on everything that we have said and shared about, without, I guess, going too far into it, is just sharing some ideas about, as a group, what health equity means. So the 3 questions that you see are prompts that we're going to be looking at while we are in our small groups, and each facilitator will have these questions, so don't worry about needing to memorize them. I would like to encourage you to go on camera if you're comfortable, but if you're at home with like a face mask on and you're chilling, I get it. It's not a big deal. Keep it off, but please feel free to join. And then again, when we come back, we are going to define health equity as a AHEC scholar group, because hopefully in the next semester and ongoing semesters, you guys can come back to this reflective time. So I think Emma's going to break us out into groups, and we're going to come back at 6:20.
We didn't put you in one. If you would like to join one, we're happy to. You're still there.
Oh yeah, no worries. I actually just went ahead and messaged Chelsea. I actually have to run because I have another appointment that I have to attend to. But
We're just waiting on one group, it looks like. But they'll get booted soon.
Okay, everyone should be back.
Awesome. Thank you. And thank you to everyone for participating in circles. It can be a little bit of a different way of kind of group interaction, but really, really powerful, and a great way to connect. We have one last question for you, and so feel free to either come off mute to answer or type your answer in the chat. But our last question is, how do we define health equity as AHEC scholars?
I'm gonna pop in because I know nobody ever wants to be the first one. There's always that awkward silence. But I think, and it's really important that when we share maybe some of the ideas and topics discussed in our small groups, that we remember that, it is confidential. So be mindful of your words. But something that came across in the group that I was in was about maybe having a lack of education around it and just always continuously working towards that education. So having that willingness. And I think that's probably one of the first steps when you think of health equity in any arena with any state. So education, being willing, and then seeking it out. There's such a difference when you seek out education rather than it being forced upon you. There's just this, something within you wants to learn, which I think is more powerful to implement into your work and your practice later. So now that I went first, I hope somebody else will pop off and go and share.
I can jump on. I think a great way to where we can try to provide equity to our equal equity to our patients is being very patient or person-centered in the care we provide, trying to really listen to that patient, understand where they are, what their circumstances are, and that can really help us make the best treatments for them, with them, so they feel really empowered in the role of what's happening to them as well.
Yeah, thanks for sharing that.
Oh, sorry, Maggie. I didn't mean to hop on yet. Our group has talked about cultural competency. And I think that when talking about equity, striving for cultural competency, continuing to educate yourself on cultural competency. I don't think it's like, as much of a destination as a getting there and a continuously, educating yourself. So we, really talked about having tools in your toolbox. And I think that's, what this kind of discussion is really good for.
I think one nice thing about this program is it's a group of people who already feel passionately about rural healthcare, and to just get together and be able to network with people, especially once we enter like practice in the field, to hear different people's experience, be like, oh, you're having trouble with that. Well, this is what we did in our rural clinic. This is how we addressed it. So I think networking and just being able to connect from such far distances is going to be critical in being able to make changes in our own community.
Yeah, I love that. Thank you.
I think can you hear me okay?
Yep.
Yeah, I think for me, it's like opportunities to help, and just, it's nice being around everybody that's positive about it because, there's solutions to everything. It just takes some work. So that's what I like about it is like, if somebody needs help with doing this or that, when a patient comes in, it's like, I get a kick out of it. I mean, it's like, great, happy to help. So, but it's just opportunities to help folks. I mean, we're very fortunate to be in that position to do that. Not everybody gets to do that. It's sort of a gift. So.
All right, last calls. Any last ideas, thoughts, questions? If anyone has any questions, we're happy to answer those either about the work that we're doing or otherwise. If we don't know the answer, we'll try and connect you.
Yeah, and I think our plan is to give Mandy all of our slides in case anyone needs them. And then of course, I believe she'll send out our contact info for anyone in those regions. Not to do a plug, but to do a plug, the health equity task forces are open to anybody and everyone. So if you found a topic area of interest and you want to, learn more about that or share your own lived experience, you're totally welcome to join that as well.
And then the only last announcement that I have is kind of housekeeping thing, is that your hour and a half from today will be logged for you automatically in Canvas, so you don't need to submit that again. And we will certainly follow up with you all with the slides and the recording to the presentation. So we really appreciate you all being here, and we'll let you go 5 minutes early, and we hope everyone has a good night. Thank you, guys.
Thank you all for having us.
Thanks.
Thanks, Mark.